So like I said, I'm a music therapist. I have my master's in music therapy. I'm board certified. These are important things. How many people know what a music therapist is? Anybody? Okay, so we have one person. All right, so music therapy's been around since, as a profession, since World War I, actually. It started out, and she's going to try to get my PowerPoint, which I was too late to send her. But she's trying to get that up, so it'll be a lot more interesting than this lovely handout that I just threw together so that you kind of had a nice, comprised thing. Oh, okay.
Just when it goes.
Oh, gotcha. Okay. So anyway, okay. So what is music therapy? Just, we have to go through some of this basic stuff so that you have a foundation. This is a comprehensive introduction to what music therapy is. So music therapy is not entertainment. It is not me coming in to see a patient and going, oh, do you like music? I'm going to play you a pretty song. Oh, did you like that? Okay, that was music therapy. That's not music therapy. Music therapy is a clinical and evidence-based use of music interventions, this is the actual definition, to accomplish individualized goals within a therapeutic relationship by a credentialed professional who has completed an approved music therapy program. This probably sounds very similar to what you guys do with, because actually music therapists are compared a great deal in the profession with licensure, being board certified because of the protocol of having a referral, an assessment, data collection, all of that, right? So we have that protocol that we have to follow for our standards of practice. It's not just saying, well, he smiled during the session, so I think he liked it. All right, success. No, there's a long, long, long process. So, okay. So we're still trying to get this. All right, so history of music therapy. And I really hope that I can get through, not that, but all of this, because I want to be able to play some music examples for you. That's mostly what people want to see. Even when I go to conferences, I want to see other music therapists actually giving examples with instruments. That's what you want to see. So, like I said, I got my master's back in 2005 from UMKC in Kansas City. Moved here about 12 years ago. Yeah, it was that long. And anyway, and so I've been, mainly my background was mental health and geriatric, and then recently, about 3 years ago, I switched over to hospice, and I'm really enjoying hospice. I've, of course, worked in many, many hospitals. Before that, I was a lab tech. Like years ago, I was a lab tech and like phlebotomist and all that stuff, in my early 20s. So I love hospitals. I'm very comfortable in them. I really thrive in that type of environment. But anyway, okay, so back to brief history of music therapy. Okay, so as far back as Aristotle and Plato, writings on the healing influence of music could affect health and behavior. So way back then. Okay, so then we jump to, all these years later, World War I. Music therapy was known to come in musicians, like community musicians. This is kind of how it started in its infancy, where they kind of came into the hospitals after World War I. Veterans were coming in, and World War II. And they were having a lot of physical and emotional trauma, as you can imagine, everything that they saw. This was the greatest generation, right? You've heard of that. Part of that was because they were the greatest generation, also because they internalize their emotions so well. If you know any World War II veterans, you probably have not heard many stories from them. They really kept that stuff inside, very strong, in their minds. But at the same time, there were still the people who needed to process through their trauma that they had seen and experienced. So they kind of noticed in the hospitals that, hey, this music is helping these people cope with what they're coming back to the United States. I'm not sure if you're aware, but when soldiers came back, they were not greeted with open arms, with jobs. That was not a given, especially in World War II. There were many people who really struggled. They were having a lot of PTSD. They were not given jobs. A lot of the jobs had been given to other people in their absence, and they were not suddenly, okay, you're out, the World War II veteran just came in, so he's got the job. It wasn't that. So they had a lot to adjust to in coming back, and plus the trauma that they had experienced. So Anyway, but in the hospitals, they did notice that it was pretty evident that although they noticed that the music helped the veterans, they also said, you know what, we've noticed there needs to be some education behind this therapy. As you guys know, psychology is pretty big in your education. Is that correct? No? Okay. He's like shaking his head, no. What are you talking about? Well, anyway, music therapy it is. Probably because we cover so many populations, we have to be really covered for every population. So psychology, you can't just have some willy-nilly person calling themselves a therapist coming in and saying, hey, let's talk about it. I'm going to bring you out of this, I'm going to trigger you with a song. You don't know. This song might totally trigger this person in a very negative way. And as a music therapist, a real one, right, profession as it is today, you know when to do that. You know how to approach that, how to apply the music in a way that brings it out in a very safe environment. Now, back in the day, when they were first kind of starting it, going, oh, music helps, they noticed, of course, we need some more education here. And training. So before entering any facility. So that's when kind of the program started. So in 1944, Michigan State University was the first music therapy program. And in several years, there was a lot of music therapy in psychiatric hospitals. So we had a lot of different associations with music therapy, a lot of music therapists in the 70s. It just kept on growing. But again, you probably, and maybe some of the older participants here, brief history. Ooh, how exciting. So basically National Association of Music Therapy and the American Association of Music Therapy joined together in 1998 to make the AMTA, which is what we all know today as the American Music Therapy Association. Oh, yay, so I don't need that. Okay. Ooh, how exciting. I feel really techie right now, which isn't really saying much. So, okay. All right, so hey, look at that. Okay, so look, and you guys can read, so I don't have to read as much to you now. So, okay, so the AMTA, that's our bread and butter. They cover our board certification, everything. So, all right, is there research to support music therapy? That's what any hospital, that's what any doctor, they want evidence. Yes, there's a ton of research out there. There are, the Journal of Music Therapy and Music Therapy Perspectives have been around since, the mid-90s, those specific publications. And then, of course, just recently, there was just in actually early September, Reuters put out something, a study that they did. I don't think it was music therapists who did it, but they did it, independently, that music therapy decreased depression and anxiety in dementia patients, which any music therapist would say, well, yeah, I knew that. But it's, it's nice that, Reuters, is doing their stuff too. And same thing with like NICU. That's, something that you work with a lot in hospitals, and music therapists are in the NICU a lot. It helps with their feeding, improves their feeding, their failure to thrive. That's diminished, when with music therapy is applied. So anyway, and again, the music therapist is educated in the proper way to know how to go in. They're not just going to come in there, loudly, all right, hey, how you doing? I mean, no, they know how to do this. Anyway, education. All right, so how is music applied so well in a therapy setting? Well, music is engaging and it's non-threatening. Think about it. So basically, my big loaded question is when I'm in an elevator or, somebody asks me what I do and I say I'm a music therapist, and they're always like, how do you do that? And that's such a loaded question. And I'm like, oh, well, which population? Which age? What's their diagnosis? It's just like, I can't sum it up. I really need to come up with a better thing rather than an hour presentation on it. And I guarantee I won't cover it all. I'm going to be running late, and I'm going to be like, oh, I got to hurry. Okay, so you guys can read, like I said. So it gives immediate positive reinforcement. It's multisensory. It's success-oriented. You immediately feel good when you're creating music with a music therapist. If I'm going to be working with you and you're like, oh my gosh, I didn't even know I could play. I didn't even know I had rhythm. I didn't even know all this, right? You immediately, self-esteem starts to go up, right? So music involves many parts of the brain, and it can bypass areas that are injured. This is very, very important. My master's thesis was all about brainwaves and the effect of music on brainwaves. It's so fascinating. I mean, you guys are very well versed on the brain, the human brain, and what it can do. It's amazing. I'm not sure. Yeah. Okay. So I'm going to go into that in a little bit. But what's the process to become a music therapist? You have to graduate from an approved university, of course, complete 1,200 hours of supervised clinical work. That's actually more than a nurse in the field. So we always say that we're like way over-educated for what we end up doing, and So and then of course to obtain and maintain your credentials, your MTBC. So, which is a very hard test, and I'm sure you guys know. So, all right. So population conditions that benefit from music therapy. As you can see, it's pretty much everything across the board. We have your. In medicine, of course, the premature infants, labor and delivery, hearing and visual impairments. When you think about it, a lot of people, you can have somebody in the hospital who's trying to rehabilitate from something, and they have a hearing impairment, and you're probably thinking, well, how can they benefit from music? Well, we all are entrained. We all have a heartbeat. We all entrain to the rhythm of our bodies, right? So we can entrain. It's called entrainment. So there's a lot of entrainment with music, and you'll do that a lot with stroke patients, with gait training. Neurologic music therapy is a lot with gait training. So I'm trying to think. Do I want to go there yet? No. Okay. So anyway, and then of course mental illness and PTSD. That's something that music therapy is being applied to a lot right now, especially with traumatic brain injuries. Alzheimer's and dementia, that's something close to my heart. I work with that. It's probably one of the main areas that I work in. And anyway, and then physical rehab, and you guys are, that's probably mainly your wheelhouse there. So, all right, where do they work? Everywhere, just everywhere. So, I work for St. Croix Hospice, so, I work in hospice right now, but right now I have a 27-year-old patient, so I'm doing a lot of what I would have applied in mental health with this guy who has, a brain tumor, and he's really struggling. He's really in denial. He's really angry. So this is all, so in hospice, it's a little bit different with music therapy. We're not making them better. I can't cure them, right? So it's a little different than how you guys with your protocol, and of course with us, but I'm just saying hospice is the exception, but where you have to see progress for it to maintain justified and reimbursed by Medicare and all that stuff. But anyway, so so I have to do a lot of mental health processing, and it's draining. There's a lot of burnout in mental health and in hospitals and any type of healthcare. So anyway. Okay, so we have halfway houses, group homes, a lot of that stuff. Has anybody in here done any work outside of working in a hospital, like in the medical field? Like what other area were you in?
My family business is in background music, so we actually install sound systems with the intent of either increasing productivity or expanding the length of time people stay in locations.
Yeah. Okay. So it's kind of neat that you can kind of see it from different angles, and so that's valuable. That's valuable in what you do. So, okay. So is it reimbursable? Yes, it is. Sometimes we have to fight for it a bit because it's just like arts in the schools. They just they see the music word attached to it and they think, we don't need that. But it's reimbursable with Medicare. That's probably why it's doing so well in hospice, because it's attached as a complementary therapies in hospice. And so anyway, it's just I don't want to read to you guys. So I hate it when people do that to me. So, and then of course Medicaid, that's the only one. Medicaid's a little bit harder to get it covered, and then private insurance. So, of course, just like with you guys, it's comparable to other professions like PT and OT. And you have to have that individual assessment, and it has to justify, validate, and that there's a reasonable and necessary intervention being documented, so, in the treatment plan. So again, all of these things, kind of validate why it's not entertainment. So, all right, misconceptions about music therapy. I've already touched on a few of them. Misconception that your client or your patient has to have a musical background to benefit or to enjoy it or to receive service, and that is no. That only one style of music is more therapeutic than the rest. No, and I'll explain more on that. All styles of music can be useful in affecting changes in patients' life. So there are 4 main criteria for figuring out what type of music you're going to apply to somebody. You have your preferences. Preferences is key. It's like honestly the number one thing. I can't go up to this you and in the I don't want to say you. Anyway, what's your name? Kelly. I don't want to go up to Kelly and say, I really get relaxed when I listen to Diana Krall. I bet Kelly will too. Here, Kelly, this is going to be your relaxing music. No, I'm going to do an assessment, and I'm going to find out how old Kelly is, because that's going to just give me a gauge. But hey, I love listening to Nat King Cole, and I'm almost 43. So, you can't just base that off of your age. You can't, not totally. But, because I grew up on old movies, and so I have that, that positive association with that memory. So and also it's really good music, okay? So, anyway, but, it's another thing. So I'm not going to go up to Kelly and expect that she's going to find another piece of music the very same thing as I do of soothing. So I'm going to say, Kelly, what kind of music do you like? So Kelly, what kind of music do you like? Norah Jones. Okay. Does that relax you? Do you find that music relaxing? Okay. What kind of music kind of lifts you up? Do you have anything that kind of gives you energy? Well, that's okay. That's okay. So, but the thing is, and also think of how I'm talking to Kelly. Kelly is a normally functioning person right now. She's not on her deathbed. She doesn't have a disease that's, preventing her from talking to me, answering me. She is, we're having a pretty easy conversation. Those are the ones that you're like, oh boy, that was an easy assessment. It's the other ones where you're like, okay, this person is asleep. I've tried to wake them 4 times, and they are just, they are on morphine, or they're terminally restless. Then I kind of have to take a little bit more of the reins on what's soothing, and I kind of have to base that off of their age. I talk to their family, music, that they liked, things like that. So anything like that is going to be comfort. But preferences is the absolute key to any type of music application. So it's all so personal. Music is such a personal thing. It taps into our soul. It taps into our emotions. I can't sit there and just give you a blank slate and go, yep, soothing music over here, energetic music over here, blah, blah. I mean, you can do a generalization, but not music therapy, okay? So there's a difference. And then, of course, your circumstances. That's your background, your environment, where you're at, your need for treatment. Are you agitated? Or do you have anxiety? Are these, these are things that I would be thinking about in an assessment. If they're just saying, I just like music, it makes me feel good. Well, is that really a need for me to be giving you service? No. I mean, I could probably just suggest a volunteer to come and play some music for you. That's not music. So I wouldn't say you need my music therapy services. So, and then of course the patient's goal. I'm going to think about what's the goal that we're going for here. Are we going for to decrease agitation? Are we going for somebody who has Alzheimer's? A lot of men are very, very frustrated. They don't know why, right? Because they know that there's something that they're just not getting, and then they have other residents, they have other family members looking at them and saying, Dad, come on, Dad, you know who Mom is, and they're kind of talking to them in that way, and they don't. you know, and they might come back, but they don't. And so the family just naturally kind of yells at them or gets a little assertive, and it makes them more frustrated. Then throughout their day, they're trying to brush their teeth. They've forgotten how. That's frustrating. You don't know why. You just know that you can't do it. You're like, there's something, you know, some gap here that's preventing me from doing this. So agitation is very common in patients with Alzheimer's. That's something that I would come in. I work with so many people in memory care units, and so often, I can't tell you how many times the nurses will say, oh, we're so glad you're here because he's in such a better mood after you've gone for the rest of the day. And I'm like, good, that's great. I wish I could be here every day. But, you know, I can't because I have like 32 patients. But anyway, but I'm so thankful that I'm able to, you know, give that reward to the staff, you know, kind of gives them a break a little bit. You know, they know that he's not going to be as agitated. No, it's not a given. Of course, they're going to, you know, a patient's going to have their off days. I'm not saying it's a miracle, and if you bring me in, agitation gone. No, I mean, of course not. You know, there are other factors. There are, you know, daily stressors that affect that. So I'm so going to run out of time. Okay. All right. So, yes, music therapy is evidence-based clinical intervention, not entertainment. I can't tell you how many times people will think that I'm just coming in to give a concert. But anyway, so the music therapy process. I'm going to go through this quickly because you guys are OTs and PTs, and you already know how, you know, what a protocol is. You have your referral, your assessment, your goals and objectives, interventions, data collection, evaluation. I don't have to explain to you, this is what a goal is, and this is how you write an objective. I don't need to do that, right? Right? I don't need to. Okay. Okay, good. All right, so referral. This is actually just a comparison between general on the left, general basic referral, and on the hospice medical on the right. So you can see the differences are, there are quite a few more indicators on the right of why you would possibly want to bring in a music therapist to address these issues, you know, emotional distress. I have a lot of times where I have a patient who is not, they're not with it, you know, they are, they're really isolating, they're not engaging at all anymore. And one of my goals is, of course, to engage with them. But when they're like that and they're just having an off day, you know, because patients have an off day, their family is there a lot of times, and I'm helping their family out, you know. So we'll sit there and I'm working with the entire group, as you know, with their family of expressing themselves and communicating with their loved one, you know, who is ill and such. So and you know, of course, through, you know, music interventions. So anyway, terminal restlessness, that's, you know, right before death. That is something that's very, very helpful. That by that point, I am just kind of doing soothing music, but I'm doing soothing music that's appropriate for the patient and for the family. It's so nice when, you know, the patient is terminally restless, and then the family says, you know, she was a Marine. Can we do the Marines hymn? And it's like, yeah, we'll do that. And so we do the Marines hymn, and then all of a sudden the patient kind of calms down and kind of just ceases for a little bit. And, you know, when you think about how hard it is for the family to be watching their loved ones actively dying and, you know, crying out and kind of writhing around, because that's what terminal restlessness is. I don't know how many of you are familiar, have ever witnessed that in hospice. But anyway, you know, it can be really hard, or you can imagine. So anyway, that's something to help the family through. So yeah, as you can see, a lot more needs on the right side. Assessment. You know what an assessment is. You identify observable behavior to be changed over the course of treatment. I can't just say, well, you know, yeah, it's going well. He likes it. I can't put that in my report. So I'm very wordy in my report. I'm sure you're shocked that I would use lots of words. And anyway. All right, so goals and objectives, again, must be observable and measurable with future goal of transferring to their daily living. The common goals, non-musical goals. You have to, with music therapy, you take non-musical goals and you're applying music as the medium, as that tool to be successful in your common goals, cognitive, social, right? All those, that array that we all know, spiritual behavior. Interventions specifically designed, again, this is what takes it apart this is what keeps it apart from just saying music makes me feel good, you know, or yeah, we have a nice, and that's one of, you might hear, if you ever hear a music therapist get a little testy from somebody claiming, or companies will claim to have music therapy or musical therapy. They think that they can get away with it saying musical therapy. And boy, you know, AMTA and the boards, they get really, really testy about it, and they just jump, and they're like, you can't say this, you can't say that, and you're misleading, you're giving this false sense of what our profession is. Stop it. Okay, so that's why, you know, we really, you know, because you don't want anybody to demean your profession and all the education that you and all the money you spent, you know, that you're still paying off. I only have 11 more payments though, so I just want to say that. Anyway, so yeah, sessions can be individual or in a group, which is a completely different thing. You do a lot of group sessions in hospitals, in mental health facilities, in geriatric, you know, assisted livings, independent livings, things like that. Individual is, of course, much easier for you to be able to address those specific goals. Again, how do we do this? Well, you might sing, you might play, and this includes me and the patient, not just me. Moving to the music, improvising, listening. Think about older patients or people who are in the hospital who are stiff and they can't, you know, you guys think of your large muscle groups, right? Who they can't move as well. Well, we start to do entrainment. And so I've worked with PTs a lot where, you know, okay, there's a music therapist on one side of the patient going down the hallway, and I'm on the other side with my guitar, and I'm playing, and we're going along with the beat, all right? And so that's kind of how you can apply that. Improvising is very nice, non-threatening. You don't have to talk. I don't have to say, how are you feeling today? Are you still mad, you know, about whatever the other adolescent said? You know, adolescent groups, anyway. You know, it's non-threatening, it's non-invasive. They don't have to sit there and talk about it because a lot of times they can't even put into words why they're feeling the way they are feeling. And this applies to patients. You know, a lot of times people who are in hospitals, they're very frustrated that they are there. They are frustrated that they haven't figured out yet what's wrong with them or that it's taking longer for them to heal. So for them to be able to self-express through music, if they're not able to do it in any other way, that's, you know, that's really important. So. And of course, listening. There's active listening, passive listening. That's just basically a different type of engagement. So, okay, then we have data collection. You guys know what that is. So, and of course, that gives validation and credibility to your treatment. And evaluation. What progress has been made towards the goal? Has the goal been met? If not, you know, is it time to discontinue and terminate therapy? I discontinue therapy actually with hospice patients, believe it or not, because sometimes we have hospice patients who are on service for over a year. You know, sometimes they're on for a week, you know, but after, if they've had some communication issues with their family members or something, you know, they're having a lot of, you know, they just have this kind of conflict, you know, going on, and we get that resolved, there's really no reason for me to go back if we've achieved the goal, and that's good. They've gotten to a new place of closure in their life. They're able to move on, and this is all about, remember, we're using music as a medium to address non-musical goals to send them off, you know, and so they can go and fly. So, all right. So, let's see, what's next? What types of music do music therapists use? Live, instrumental. Vocal music, usually interactive. So you don't see recorded music a lot because I think a lot of music therapists would look at somebody using recorded music and think of that as a cop-out. Because, I mean, sometimes I'll use it as a reward at the end of a session, and if they want to say a scene from Singing in the Rain, all right, which, how does that not make anybody happy? But anyway, so that's okay if it doesn't. It's your preference, you know. See these guys going, Singing in the Rain. All right. So yes, so I'll use it as a reward, and we'll sit there, and that's something that they get to watch. They probably haven't seen it. In this day and age, it's amazing that I can look up on YouTube and just look up a little, you know, snippet, and I have a video, and it's like, oh my gosh, 20 years ago, I know you guys think this is whatever, but it's really cool that we're able to do this. It's an amazing resource, but you would not sit there and just say, here is some music, and I'm just going to play this on a record, and I'm going to leave the room and enjoy. You know, that's not it. I have to know, are they getting agitated? during, if I start playing a song, I've had people who they love the song. I've played it for them 5 times in previous sessions, and then all of a sudden, they don't want to hear it anymore for whatever's happening in their day. And I have to recognize that and read the situation and read the patient and go, okay, he's starting to get agitated. He's starting to get distracted. I need to change it. I need to bring him back over here. I need to redirect him over here. Happens a lot with patients with Parkinson's. I have, quite a few with Parkinson's. And that's something, you're always redirecting them. So you can't do that if you're just, well, I got the music on. That's our music therapy. No, it's not. That's not music therapy. So you guys understand what I mean? Okay. I'm making sure also I'm blah, 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 blah. All right, age appropriate, right? We have to have age appropriate music. You can use recorded music. And then patient preferred. Super, super important. Huge, 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 huge way to get in. All right, so is it backed up by research? Yes. All right, just a few to mention, blah, blah, blah. Yeah, so decrease depression, all that stuff. So again, you guys will get this, I guess. Musical stimuli processes in the brain, of course, goes to the auditory cortex, it goes to the thalamus, it goes to the amygdala, it goes all these things, right? And then all of that causes the chain reaction to reduce the epinephrine and norepinephrine, the fight and flight, and then of course it helps with cortisol levels. What does that do? That when you lower those, you're able to raise the other good things in your brain to where you can sit there and suddenly have your frontal lobe, all of your reasoning and all of your very important decision making in the frontal lobe, your impulse control, all right? Problem solving, memory, spontaneity, social behaviors, such. So anyway, all right, so there's that. And then there's neuroplasticity. I don't want to go into that. I don't have time. You can read it, though, when you get this in your thing. So, all right, so rehab, medical. All right, so this is where I'm going to do a little bit of musical examples. All right, so goals. A lot of times gait control, speech production. There are a lot of people with strokes. And I have people with strokes. I have patients with strokes in hospice. So, and their family's like, well, they had a stroke. They're pretty much done. It's like, but if I'm able to get that person to sing, right, in a session, and the family sees that, and they're just like, it's just amazing to them. They have this new engagement with this person that they didn't think that they had anymore. They didn't think they had any relationship left with them. Sometimes it just happens once. It might happen twice in a session. It might not happen at all. It might happen to where all of a sudden, I don't get anything for most of the session. Then all of a sudden, a patient will suddenly start talking about something in a very steady speech rhythm, and you're just like, well, that was cool. Boy, I wish the family was here to see that, but I'll write it in my notes. So, but things like that. And, you think about if you have a loved one in the hospital or in a independent living facility or assisted living, wouldn't you like to know that that person is living in there and they're not just sitting in their room isolated? That kind of makes you sad, right? If you think about, yeah, my dad, he just sits in there and he doesn't talk to anybody. He doesn't go to meals. He's just depressed. But you have music therapists come in and engage with that person, and you didn't even think they could engage anymore. These are all really important benefits to music therapy. And again, music therapy, it's very sneaky, sneaks in the side door. Oh no, we're just going to have some music. Ha ha ha. And then all of a sudden they're opening up about something, or it triggers something in their brain. New neural pathway is created. That's the whole amazing thing with the brain. Of course, you know that. All right, so goals focused, improvement, not maintenance. Neurological music therapy, that's an actual certification. A lot with gait training. So, and then we have traumatic brain injuries. That's something, it's really, they're talking about it a lot, as I said, working with it a lot with music therapists. They need a lot, that's kind of a cross between mental health and their brain injuries. Nonverbal expression of inner thoughts and feelings. How important is that? When you feel like you haven't been heard, right? So, all right. So, let me think here. Because I don't want to run out of time, and I will. All right, so let's pretend that you are a woman who's in her 80s or 90s, let's say 90s, and she really gets around, and then she has a stroke. she's one of those, just real go-getters, right? Like 95-year-old go-getter or something, or 91-year-old. And she sits there, and she no longer can walk, but she wants to get down to the dining room. So, but she doesn't feel like she has the strength. And then say the PT is like, we just cannot get her up. She doesn't want to do it, right? So, and then let's say she likes Doris Day. All right, not all of you like Doris Day, but she likes Doris Day. So that's what's important. All right, so I would come in, and just with the rhythm, I normally don't sing this low, okay, but when I was just a little girl, I asked my mother, what will I be? Will I be pretty? Will I be rich? Here's what she said to me. And then, because she knows the song really well, I'm going to go, que sera, sera. All right, I'm going to start that because she's probably sitting and maybe the PT's with her or something. And then we're going to just, maybe if she stands, the PT, and then we'll be like, whatever will be, right? Because she starts moving with it. She just a little bit of her heels, all right? She's kind of going with that. The future's not ours to see. Que sera, sera. All right, so we're just kind of getting her moving, getting her hips loose, if her hips are okay, of course. But a lot of times it's just kind of this. And they have a walker or, the PT's with them with the gait, with the belt. All right, and then we go back into and then we see if, maybe she's at the point where she's ready to take a step. So if I just played this and said, we're just going to play Que Sera, Sera, and Doris Day is just singing it, and I have it just, like on my iPhone, Que Sera, Sera, da da da, right? We can't do that because she's going to fall over and get hurt. She can't in train, all right? That's in training. So, and we all have a heart, right? And you guys know, how many of you, a song plays and you were just like, I cannot help it. I just have to move. I don't care. I just got to move, right? We have to move. And if you aren't moving, you want to move, okay? Because that's just how it is. And so anyway, so then it'll be, and then we'll start. When I was young, I fell in love. Pretend I'm walking. I asked my sweetheart, what lies ahead? Will we have rainbows day after day? Pretend, she's not taking quite a step, right? But she, and I will go with her. Here's what my sweetheart said, right? Que sera, sera. Whatever will be, will be. The future's not ours to see. Que sera, sera. All right, so it's kind of like that. So it's important for me to follow along, right? We can't just, again, just say, you're on your own. Yeah, go. Hurry up. So, all right, so then, what else? Let's see here. I want to do a drum. Drums are very fun. A lot of people love drums because they're a drum, right? This is a buffalo drum. I have lots of drums. I have lots of instruments, but I didn't want to bring everything. We have paddle drums. This is a nice drum because it is big and it's boomy, but it's not loud. It can be loud, but it's not loud. So you can hit it, So it hangs, okay? It's suspended, so it's very Native American thing going on here, right? All right, so I will, with my patients with Parkinson's, Parkinson's a lot of times, right, the verbal speech is gone, those skills are gone, but the rhythm remains. Same thing with Alzheimer's and dementia, right? So that's why I can sit there, so pretend I'm sitting and the patient's sitting, in front of me. I will put the drum, on balancing on both of our knees. Of course, I'm controlling it, I'm making sure. And we're just gonna play a beat. We're going to sing along to a song. That's why voice is very important. Voice is an instrument, in case you didn't know. So let's see. I'm trying to think here. What do we want? What song do you guys want to hear? Well, no, I see this. I don't want to waste time. Okay, sorry. I'm so going to run out of time. All right, so pretend this is here, and we're doing Raindrops Keep Falling on My Head. That's just because it was next. So, all right, so we're going to raindrops keep falling on my head. All right, so we're just kind of doing this, right? And it might be to where the patient doesn't give me anything back. But his hands are here, and so I'll do a hand over hand, if I need to, and I'll kind of, right? So you go there. I need more room. Anyway, so here's my hand, here's their hand, and I have my hand over their hand. So he's just kind of feeling that vibration. A lot of times with people with Parkinson's, they're kind of in this frozen state, and they need that visual or auditory cue to snap them out, and then they will start. I mean, I can't tell you how many times I'll do Brown-Eyed Girl with this one patient who has Parkinson's, and every time he just snaps out of it and he just starts, Brown-Eyed Girl, and you're just like, okay, all right. But he's engaging. He's having this positive experience. So much better than his family thinking he's walking around the facility, going in other patients' rooms, having behavioral problems, right? This is a positive thing, right? That's so much what it is, to bring positive associations and memories into this person's life, in the here and now, not to write them off just because they're ill or, whatever. So, and then anyway, so with the rehab, so that's really helpful. So I want to think. Okay, I want 2 people, please. Who wants to play a drum? 2 people. Come on. I know Kelly wants to come. That's just because I know Kelly's name. That's what happened. Here, okay, no, and I'm going to bring you the drum, okay? I'm trying to help. All right, there.
I'm so not musically inclined.
This is perfect. This is perfect. Seriously, you're going to be fine. See, brave Kelly. All right. So now we're not going to talk, okay? We're not going to talk. All right? So I'm, pretend there are more people with different instruments, shakers, bells, things like that. But, okay, so how are you feeling today, Kelly? Are you kind of you're nervous? Okay, so you're a little nervous. All right, so, well, that's fine. That's fine. So you're feeling a little nervous. How do you feel when you feel the best you can ever feel? Do you feel excited? Do you feel energetic? Do you feel happy? Do you feel optimistic, right? Okay, so that's a better feeling than feeling nervous, right? So this is just, obviously I'm not going to have a lot of people who are nervous, but normally we're addressing something else. Maybe they're irritated or something like that. But the whole goal is to come at them in a very nonverbal way, except for, yes, I did. I was just trying to get a sense of that, where you were at. Okay, so you can use the ISO principle, where you are going to where exactly that person's mood is. You apply the mood that they are presently, and you elevate from there. Or you go down if you really want to be mean about it. But it depends if you have to process that way. But anyway, so I would never do that in a group setting. But okay, so I'm going to be the main drummer because I have the biggest drum. And anyway, but you have to have, the music therapist has to be kind of the steady beat. So I'm just going to go. This is improv, okay? So Kelly is going to just come in whenever she wants to, and I'm going to just, okay. That's perfect. Okay, and now I want to get louder. And I want you to get louder too with me. But pretend I'm not talking, though, okay? And she naturally quieted. And now, Kelly, I want you to run it now, to where I want you to go with the speed and the loudness according to you when you want to. Okay, so I'm going to follow you. I'm going to give the beat, though, but I want you to control the volume and the intensity, okay? All right, so. support what we're doing. Complement it. Kelly's still in control. When she wants to stop, we will. Okay, so that was a very, very basic, tiny example of how we were supporting Kelly. We gave her some control. So we did like a first example, you know, okay, this is, you guys are going to follow me. And a lot of times when you have people, when you have especially adolescents with a lot of, you know, anger, they all have different instruments, and they are, you know, just like, they are so excited to be hitting something so hard. But one of the rules is you have to respect the instrument. You cannot be out of control with it. It's like, yeah, you can get as loud as you want as long as you're in control and you're in the rhythm and you're with the beat. We were all supporting each other. So Kelly was in control, though, that next time. And then I asked you to come in complimenting what she was playing. So, I mean, that could have gone on longer. We could have done different instruments and such. But that just kind of, it gave a way to where we were all supporting however you were feeling, whatever you wanted to do with that emotion. You could have gone and been, you know, but you didn't. I mean, that's fine. But no, you guys did great. So it's just an example. Okay, so, and again, pretend I wasn't talking. So it was all nonverbal in your mind. So, all right. Let's see how much time we don't have. All right, hospice palliative, I already talked about that a lot. Common goals, pain control, a lot of pain management in music therapy with hospice. I've had patients who say, you know, they've asked, they have not wanted any other therapies, and they've said, you know, but I liked music. I used to kind of fiddle around with some music, and I was interested in that. So I'd like to try music therapy. Okay, all right. And a lot of times it's just giving that person control over the situation, the song choice, and they get to choose, and then we go through the songs, and we play what songs they want. We play it in whatever style they want. They're getting so much control out of that situation, and validation and self-esteem, because maybe they didn't know that they could play music, or you know, music is so, it's so special when you create something in music. When you sing a song, think of all the times in the shower when you're singing a song and you don't think anybody can hear you, and the acoustics are really good, right? And you hit that one note, and maybe you're like, oh, that sounded good. You know, and you just kind of, you're just like, that was cool, that was fun, all right, you know, and then of course, you know, somebody probably makes fun of you for singing if they caught you, and you're like, well, I'm never doing that again. But, you know, but how much joy it brings you, you know, you can imagine. So, okay, one thing with hospice is that you have to document an overall decline, you know, so it's a little bit different than other music therapy. So, let's see, yeah, we can do it. All right, so with hospice, an example would be, let's see, something, you know, if they're like, you know, I'm just really feeling, they're just really feeling, say they like Irish music a lot, and they just need some comfort or something. And so this is how I would do this with Danny Boy. Oh, Danny Boy, the pipes are calling from glen to glen and down the mountainside. Now, if they want to sing, then I'll be like, the summer's gone, and then they'll sing with me. And all the flowers are dying. 'Tis you, must go, and I must bide. But come ye back when summer's in the meadow, or when the valley's hushed and white with snow. 'Tis I'll be, and then a lot of times they like to sing this last part. There in sunlight or in shadow. And sometimes we will change the words. So 'tis I'll be there in, Millard. I've had somebody say that before, because they just wanted to go home, and they wanted to be there. So they're imagining being home. So we've changed the words, and 'tis I'll be there in Millard and at Christmas. Oh, Danny boy, I love you so. So you can change words to a very familiar song, something that means a lot to them, something that touches them. They haven't been able to kind of express any other way, and we'll, change a word or something. So, and that's seriously tiny bit. So let's see. Okay, so geriatric, nursing home, elderly care. Goals are normally well-being and maintaining functioning. And then developmental delays, it's on the bottom there. Goals are related to maintaining functioning, socialization, cognitive skills, and life skills. A lot with life skills on developmental delays. Okay, using the benefits of music outside of the music therapy profession. That's kind of what anybody who's not a music therapist but wants to use music would do and would apply. So, an iPod program, you're hearing some people, some hospitals saying, we gave out iPods for all of our patients on the rehab floor or in the cancer wing or something. And that's great. I mean, that's wonderful. But you cannot say that's music therapy, right? So singing and playing for relaxation, that's all personal. My husband is not a music therapist. He's not a formally educated musician, but he plays piano and sings practically every night because it's relaxing to him after his job, and that's do your thing. Music as recreation. You can draw to music. You can lead a choir, reminiscence groups. Those are really nice in assisted living facilities. They'll have the activities therapists will have reminiscence groups. Again, there might be music incorporated in that, but it's not music therapy. Music performances, if you're in a choir or a community church thing or something, perform. Sing-alongs where, all right, everybody, let's, we have a songbook. Oh, that's not music therapy, but awesome way to apply music. And then jam sessions, if you've ever, I don't know if any of you are, I should have asked, are any of you musicians? Anybody play anything? What do you play? Piano. Oh, okay. Yeah, piano's my main instrument, so as you can tell. All right, so, and then we have our resources here. But, again, I'm glad you guys are going to be able to get this so you can refer back to it or what, and if you have any questions. That first thing, I don't know if you'll also be sent that, will they? The first handout thing?
It's on the registration site.
Okay, so there are two things. The first thing is kind of like a handout, like your basic thing, and then, you have this. But anyway, so, gosh, I can't believe I'm stopping. Well, I'm not stopping quite yet. Are there any questions? Because I'm sitting there thinking back, going, did I even give any idea of what music therapy is? I don't know. So are there any questions? Anybody? Give me a question. I have like 2 minutes. You don't want to hear me sing again. So, okay.
I guess for us, objectifying goals is huge.
Yeah.
So how do you objectify, what they're feeling, or how do you just say, they're agitated only 50% of the time now?
Oh, okay. So how do I measure it?
Yeah.
And then, okay, so depending on the patient, a lot of it's you recognize what the patient is generally capable of, but through their affect gestures, sometimes you're going to just get nodding, positive statements. Yes, I should put that in there. I'm going to put that in there to put an example of a measurable goal so that you can see that better. So it might be to evoke positive memories, and I don't know, evoke positive memory associations, decrease anxiety, improve quality of life. You don't want to say improve quality of life too much because that's so generalized, and of course their quality of life is going to be improved if they're, having any type of therapy, right? They're going to have their quality of life improved. So we try not to use that too much. But yeah, it would be decreased agitation. So it would be possibly that maybe they, if I play 10 songs, it might be that they responded. I will give them 2 choices generally. I'll say, here are these 2 choices. I'll give a little musical example depending on how much cognition they have. And they'll choose a song. And just that gives them empowerment. So it might be that and then I will do a verbal prompt or a musical prompt to evoke positive statement from them. So if they're dealing with depression, positive statement, something like that. So initiating ideas. And so I'm going to measure that by they, responded, made positive statement 5 out of 10 times. And of course, I don't have some person over here marking down my data for me. I have to kind of remember it. Okay, they did that 5 times. All right, notch. But yes, they're nodding, they're gesturing, their affect. They started out with flat affect, became more animated throughout the session. This has happened 3 out of 4 times. It's a little harder with hospice. When you work as a music therapist, when you work in the schools, in autism and mental retardation and such, there's a lot more, it's a lot easier for them to, when you're working with somebody with wanting them to pick up an instrument or grasping or creating daily living skills, it's a lot easier to say they reached for the brush and successfully brushed their hair 3 times out of 5. That's easier to observe and measure than somebody's feelings about something. So you kind of have to measure it a little differently. So you get stuff more about like positive statements and or decrease in negative statements. Yes.
Is there kind of use of like self-reported quality of life scales, like her depression scales that you can use?
Well, a lot of times the music therapist is not assessing their depression in the beginning, but so we'll come in with that referral that they have depression. So that would be something that maybe the psychologist or the nurse or even the medical director would, talk to them about. That's across general medicine and hospice. Because I say it like that because hospice just has a little bit of differences there. But so no, but with the depression, you would say, but a lot of times then you'll find out in the IDG meeting that so-and-so no longer needed their depression meds, or they didn't feel that they needed them, or they were making much fewer depressive statements. And when I'm working with somebody young, there is a lot more processing going on, so it's a lot more like a therapy session using music as that sneaky medium tool, and they don't even realize it, and they're having a lot of denial about the fact that they're 34 years old and they're going to die. That's not anything that anybody would plan when they're 34. It takes you a while. So there's a lot more lyric analysis. I'm sorry, I did not go into that. So yes, lyric analysis where you break down a song, and that's my job to come up with a good song. We might write a song, songwriting, about how they're feeling at that time. That's so cathartic for them. It helps them process, and there's no judgment. A lot of times they don't want anybody to hear it. They just want to do it for themselves. And I'll even say, do you want to keep this? And sometimes they do want it. They want the song after we've written it out and all that, and they want to keep it. And then sometimes they say, no, you keep it. I want you to have it. Because they know they're not going to be there. And so it just depends. It's all personal. It's all preference. That's why it's so important. You can't push your views or your feelings on anybody, or your processing, your state in life. So yeah, it's so individual. It really is. I hope I answered that question okay. But yeah, I didn't. Yeah, there's lyric analysis, songwriting, all sorts of those things. So improvisation, lots of tools in my bags. So, but anyway, so any other questions? No? Okay. Thank you guys so much.